It's been a great couple of days. I was just so impressed with all the talks yesterday and today. And I hope you'll find this interesting as well. So I want to talk about a sort of a variant of vestibular schwannomas. So obviously a lot of very experienced vestibular schwannoma surgeons here on the panel with me today. And these are some of the types of vestibular schwannomas we see. None of these are the variant that I want to talk about today. And for most of us, although it can be challenging, it's a relatively straightforward procedure, getting a good resection, protecting the facial nerve in a vestibular schwannoma. You don't expect a lot of intraoperative bleeding, and even if there is, you can manage it. And historically, although I don't routinely do angiograms on them, but on people who do, they consider this a sort of hypervascular tumor. But I want to talk about a subset of these tumors, hypervascular, very vascular vestibular schwannomas. There's not a lot in the literature about it. It was a very good series that came out from Michiro Kono's group, the Japanese series in 2017. But we've known about this again from mainly Japanese papers, first talking about this back in 1986, where they talk about a high concentration of these vessels. And the key feature is rapid shunting of blood through these vestibular schwannomas. And the shunting or the vascularity can be so great that they actually, a lot of these papers, like you can see the paper at the bottom left, talk about staged surgery. They tend to be quite large tumors. They tend to be younger tumors. In my small experience, I don't think they're related to NF2. We're a large NF2 center here in Oxford, and I don't believe that these are actually NF2 related. They tend to be solitary vestibular schwannomas in young patients. This is a nice description I took from the Tokyo group, just talking about the different types. And really the ones I'm going to talk about are the sort of type 2B, which is the most complicated. So you're looking at this large blush, rapid blush, because of the shunting of blood, both from the vertebral basilar system and the external carotid system. And the 2B type is the complicated type. Even the experienced Tokyo group talk about staging those operations because of the rapid shunting of blood and high vascularity from both the vertebral basilar system and the external carotid artery systems. And this is just a selection of some of the cases over the years that we've had, with some, unfortunately, with very, very poor results. So the main case I'm going to talk about is this 24-year-old. You can see they're all very young. So we've got a 24-year-old gentleman, a 21-year-old lady, a 19-year-old lady. They're all very young. They all have large tumors. This one's, I'll show another picture. It's about 4.5 centimeters. It's even slightly larger than that. They're all large and extremely vascular. And really the result we're looking for is like this case here, where there's only a very tiny bit left behind to protect the facial nerve. She's got a very mild facial palsy that I expect to improve. And occasionally you have to end up staging it, a bit like the case I'm going to show today. So in the 24-year-old gentleman, where we've got a good debulking, but nobody would leave that much residual tumor, particularly in a young patient. There's a reason why I had to stop at that point. His facial nerve is still intact. And this is probably the first patient from many years ago, which unfortunately has had a very poor result and has failed surgery and radiotherapy, has a facial weakness and lots of other neurological problems. And actually when EMAD asked about talking about cases, what would you have done differently? I thought about this one and how it's influenced all the future cases we have done. So I'm going to focus today on talking about this patient and this syndrome. So he's 24, he's otherwise well, and he presents a progressive hearing loss, becoming much more unsteady. His walking is becoming unbalanced. He has a 6 nerve palsy, and he's starting to get headaches in the morning. And this is what his scan looks like. So quite a sizable tumor, as you can see. It's about 4.5 centimeters. It's got very slight enlargement of the ventricles, not enough for us to put an external ventricular drain in. Although he did have papilledema, but what we really wanted to do was deal with the acute problem. Okay, so what's my sort of thinking on how we manage this? I think the most important thing is you have to realize that these are different to other vestibular schwannomas. As I said, most vestibular schwannomas, it can be challenging, but actually you expect to get a very good result there. And you have to understand that this is a different operation and this is going to be much more challenging. You can consider staged approach. We have used that before. You have to decide, you're going to go retrosigmoid. What are you going to go for? Do they need EVD? My preferred approach is going for the cistern, but that can be very difficult in young patients with large tumors, but that's something to think about. I think an EVD is not unreasonable. I personally don't use lumbar drains a lot, and I certainly don't use it with large posterior fossa tumor. I also don't embolize my tumors, but I think some people would consider that. There are downsides to embolizing. I'll talk a little bit about that when we look at the angiograms, but I personally don't embolize, but I think that's, a very reasonable consideration. So these are some of the things we've thought about, and you also get from the papers. There's an interesting phenomenon. I think Andres Grotinas spoke about this last time, that for some reason, partially resecting them, even if you don't get the blood vessels, and we saw that in that very first case, it reduces the hypervascularity. So they sort of autothrombose. And it's not entirely clear why that happens. 2B lesions, as I described earlier, this where they're being fed from both systems, they're the challenging ones. And wherever possible, even if you can do it in one stage, as in the second case I showed, that's favorable, I think. Obviously, we always want to protect the facial nerve. We'll talk about embolization a little bit. Again, I don't favor it. And some of the papers suggest that these behave a bit like AVMs, and there's a change in blood flow and you can get cerebellar swelling. I certainly saw that in the case that I had to back off in this case I'm going to talk about. I actually don't think that's the case. I think it's just a long operation, and because they're so vascular, you don't rapidly take the volume down as you normally would to really relax the brain down. And I think that's the sort of issue here with cerebellar swelling. I do like a large craniotomy for all of these. I routinely open the foramen magnum for them. I think it's just safer post-op. And I'm using standard techniques, but going quite aggressively with the hemostasis. Okay, so I know we have a lot of more junior people joining us. So just a quick discussion about what approach you would choose. So just to orientate everybody, this is the transverse sinus, this is the sigmoid sinus, and then you're looking down into the CP angle. You got the descending segment of the facial here and the labyrinth. So the options are to come behind the sigmoid sinus, retrosigmoid. That's my favorite approach for these. That's what I used in these cases. I think translab is very useful. I'm going to use that as a second stage for this case. And you'll know from my previous talks, for a lot of cases, particularly petroclavian meningiomas, I really like the trans-petrous transtentorial, so where we do a supratentorial craniotomy, middle fossa craniotomy. I go right through either retrolab or translab. I combine that with an anterior petrosectomy, and I cut the tentorium, and I think that gives a fantastic view down. And I have used that in one of these cases as well. But for the case I'm going to talk about, it's just going to be a straightforward retrosigmoid approach, and I think for a lot of these, that's enough. But as a skull-based surgeon, of course, you should be able to do all of these approaches. Okay, so this is the patient I'm talking about, just to show you it's a large opening. That's the craniotomy there. And you can see I've opened the foramen magnum. I've not taken C1 because I don't think it's needed. I've not drilled towards the condyle because I don't think it's needed. All I want is really open low. So I have a good chance of getting to cisterna magna or any of the cisterns. I don't think there's any advantage in having to drill the condyle. This is not a foramen magnum meningioma or something like that. And that's just the anatomy from Roton for our junior colleagues who are joining us, just so you understand. For most of your craniotomies, you know how the post fossa changes angle. You must get at least to this point. It's much easier to access cisterna magna, which is the first thing you do when you get in. I think it's even easier, particularly in young patients with big tumors, to just open right down to foramen magnum. That involves understanding how the vertebral artery winds around in that area. There's no need to take the C1 lamina. This is not a foramen magnum meningioma. You can see I've left the bone out here because we had some swelling. Okay, again, for our junior colleagues, just so you understand the anatomy, this is the view you get in a retrosigmoid, a bit more than the standard view. The tentorium has been cut here, so it's not your standard view. You won't see 4 so clearly in 5, but you get a pretty good view of 5. Then you've got 7 and 8, and then you got the lower cranial nerves down here, and you can see the ICA winding through that. And understanding the anatomy of the ICA and the superior cerebellar arteries are very important in vestibular schwannoma surgery, particularly in these cases. Okay, then the next consideration is what is the blood supply of a vestibular schwannoma? And it's interesting if you look through the literature, again, maybe I've missed out, but there's not a lot of papers on this. But looking through the angiograms that we have done, again, we don't do a lot of angiograms, but I find these hypervascular ones very helpful for understanding the anatomy. The first thing to understand is there is a clear external carotid supply. Ascending pharyngeal, clearly mastoid artery supplying some of these, but it is described. The tentorial branches definitely supply the tumor as well. And then, of course, the big feeders are from the SCA and ICA usually. So you've got very clear, large feeders, particularly in this case, from the SCA and ICA. And interestingly, also from the short perforators coming off the basilar. The pica can supply, but again, in this case, didn't really see a lot of supply from the pica. But you've got to understand that this is the blood supply of vestibular schwannoma, and how you're going to tackle all of this, either embolization or I think my preferred choice is dealing with it intraoperatively. Okay, so the bottom picture, which is the least clear one, is just to show that tentorial branch coming to feed. But really what these angiograms, and I know it's not the same as flicking through the pictures yourself, but what it really shows that even in early arterial phases, you're starting to see the shunting of blood very quickly. And what you find, if you don't time your CT angiograms and things well, you won't realize how vascular it is because the blood shunts so quickly through it. So if you're in a pure arterial phase, you might actually miss out on how vascular these tumors really are. And then you can go on to see there's almost two parts of this tumor, isn't there? There is a vascular but less vascular part compared to the deeper bit, which is extremely rich blood supply. This rapid shunting of blood into the venous phase, mainly being fed by the ICA and this sort of large branch coming through the middle from the ICA and SCA feeders. So this is the vertebral basilar and internal carotid angiograms. And then understanding the external carotid supply is key. So I've annotated it just so it's very clear for everybody. So the first thing you have to understand is middle meningeal coming up to spinosum for that sort of classic turn. And here you have the petrosal branches as an accessory branch as well coming through. Now, the difficulty, of course, is accessing these branches to sort of embolize it. And if you want to embolize something, I think the external carotid is not a bad option. But you run into real difficulty because you have to understand, what the rest of the anatomy is. So these yellow arrows, this is the internal aortic canal. This is sort of feeders coming towards the area of the genicular ganglion. So it's actually very easy. Well, sorry, first it's technically difficult, but then secondly, it's actually very easy to start injuring or making things ischemic that you don't want. It's obviously the tumor there. Then you've got ascending pharyngeal. And understanding the ascending pharyngeal branches, inferior tympanic artery. Superior tympanic is obviously a branch of middle meningeal. What the superior tympanic artery does, how it enters in through the jugular foramen. How the branches enter through the jugular foramen and also through, along with Jacobson's nerves, how those vessels then come up to feed into this tumor is very important to understand. And as I described earlier, but probably the easiest bit to get are the occipital artery feeders, these transosseous branches coming off the occipital. So all of these are important feeders as well that go on to supply the tumor. And you can see the blushes coming from both internal and external. Some of these ascending pharyngeal ones can anastomose with the vertebral-basilar system. So again, not a good target, I think, for embolization. So my preference is not to embolize, but I can fully understand why other people would. And it's certainly something you must consider. Finally, the final thing I like to do is this 3D spin. We've got excellent neuroradiologists here at Oxford, and they give this sort of double contrast view and then do this 3D spin, which I find extremely helpful for really understanding in one view, in a view we're used to. The double contrast is, it differentiates between this bright arterial. This is a view of the top of the tumor, an axial slice right at the top. Big feeders, SCA feeders at the top, how that's going into the veins. You can see small amounts of arterial phase already in the veins, how vascular the tumor is in the deep aspect, where the veins are here on the deep bit, how this picture on the right to the coronal view, what it's showing is the huge feeder going through the middle of this tumor and all the little branches coming off the ICA. I find that very, very helpful. There's also a flow-related aneurysm picked up here, just where the labyrinthine artery comes off the ICA. So this is, in terms of preoperative planning, is all incredibly useful to know. You can see there's almost two phases of this tumor. The deep bit is even more vascular. So you know you can make rapid progress, hopefully, in the superficial or the lateral part. As I said, you can put an EVD. I think that's fine. I don't use a lumbar drain. And then it's really about going for the cisterns. In this case, there's almost no CSF in cisterna magna. And so you're looking at really at, the cisterns at 11 there. There's lateral medullary cistern and it's incredibly tight, even with very, very good anesthesia. It was very, very tight getting into this brain. And that bit is critical. If you injure the cerebellum or anything, your operation then becomes even harder. And getting the initial CSF is what made this possible. Okay, so just to summarize again, I think you should do a big craniotomy, open to foramen magnum. You have to get the CSF, expect a lot of bleeding, but you should be able to manage it. The other thing I find useful is actually minimizing the use of the ultrasonic aspirator. Otherwise, the bleeding just becomes very hard to control. Sort of old school technique of using the bipolars to try and resect tumor. I'll show a bit of that in the video. And it's only after you really debulk the tumor down that you have any chance of doing the standard arachnoidal dissection technique that you would use in a vestibular schwannoma, and you've got to keep an eye out for cerebellar swelling. So I'm just going to show the video. So I'm sorry, I couldn't show you how this is actually after I've drained a bit of CSF from the lateral cistern. It was much tighter than this was. And this is, of course, much tighter than a normal, VS surgery would be. Normally, by the time of good anesthesia, nice craniotomy, drain cisterna magna, you got quite a bit of space already. The cerebellum has fallen back. You can rapidly, so I'm just trying to peel some of the arachnoid back. You can rapidly debulk into this. And you get a much more relaxed brain. I mean, this is not a relaxed brain at all, and not in any way typical, I think, of a vestibular schwannoma operation. And I can't rapidly debulk here because of the vascularity. So I'm being cautious initially. I would like to do a lot more arachnoidal dissection. I think one of the worst things you can do, obviously, is to fuse the arachnoid in any extraaxial tumor. Fusing the arachnoid onto the tumor is just criminal. But anyway, I'm already, as soon as I got in, I was starting to get some bleeding from that sort of petrosal branches. So I've started there, tried to do a little bit of debulking and having to coagulate. I have to say, I'm not a big fan of bleeding at the best of times, and like to keep it under control. I like to have a sort of nice cavity the blood can run into inside the tumor. So working the lower pole, I'd like to get more CSF. You can see the low cranial nerves here. We're just starting to separate away the tumor. Got a reasonable understanding of what's happening with the anatomy. So I can start to coagulate. I know I'm away enough from some of these. And I'm using the bipolar and trying to stay outside the tumor actually as much as I can. When I go inside, it's usually to use the bipolar to debulk. Not too bad, actually, at this point. I think we've stopped a lot of the early bleeding we had. Just going to skip forward a little bit. So it's starting to come away. Low cranial nerves are starting to come away. Taking some of the feeders there. I'll just skip forward some more. The video's a lot of staying in the same area and trying to get on top of it. And I'm also getting CSF the whole time, which I'm happy about. And things are relaxing down a bit. I think we switched to sharp dissection at some point, and those nerves come away quite nicely. Unfortunately, we have safety scissors, so this is like pulling away rather than just a pure cutting. Yeah. Okay, and a bit like in a hemangioblastoma, I know where the facial nerve, I've not picked it up yet, and it actually turns out to be much deeper. I know I'm safe. So you can see quite significant feeders to this tumor, all of which we're going to take. And I'm very clear from the angiogram, what I can take, what I can't take. So we're just continuing to clear away, still working at the bottom. I think I'll skip forward. And as much as possible, I'm trying to, a bit like a hemangioblastoma, really take the outside of this, coagulate it down. Just keep going with that. So I'm going to skip forward. I'm going to come to the top of the tumor soon. It's more just coagulating. Coming up top, I'm expecting big feeders here as well. I know from the angiogram there are big SCA feeders. That's a branch going into it that I've just taken. Yeah, so now this is the bit where I'm using the bipolar. I've tried with this with the Sonopet. I actually found that much slower. The Sonopet, you can see there's quite extensive, bipolaring going on in this case. And I'm actually debulking the tumor down with the bipolar, and that was actually the best way to make progress in this operation. And that goes on for a lot of this operation, is actually trying to get the volume down that way. Anyways, we get the volume down, we start to come, and we're going to pick up 4 and 5 at the top. We're going to pick up the SCA, so that's the fourth nerve there, and the arachnoid. SCA and the feeders are here, part of the Dandy complex that it's feeding into. So you can see once you get the volume down, actually it comes a lot more like standard vestibular schwannoma. It's just all the bleeding issues. Yeah, I'm just clearing away the arachnoid. I'll skip forward here. You can start to see the feeders and the depths, and I take the branches off that. Okay, so we're coming down onto 5. We're going to come onto brainstem in a minute. I'm just working out that there definitely is a feeder, which I take a bit later. Just taking the branches coming off it. So I'll just skip forward. So we're coming down towards the brainstem here. So it's got very nice arachnoid planes. That's 5. Oops, sorry. We're now on the brainstem. Now here on the brainstem, I just haven't got the volume down as much as I'd like to. It's not as, the brain's nowhere near as relaxed as I'd like it. There's a bit of swelling. That was just that bit there was me taking the feeders off the brainstem. It's just to show that it peels off the brainstem, but everything is just a lot. It's a nice plane along the brainstem, but everything's just a lot fuller than I'd like it to be. So I decided I should stop. I'm going to come via a separate approach. So I stopped because I felt it was just a little bit of swelling there. I don't use retractors. I like everything nice and relaxed when I'm doing things. So I got about 70% of it out, but obviously there's still a lot left. You definitely wouldn't leave this in any patient, particularly in a young patient. So I'm going to go back in on a staged approach that some of the papers recommend. But the patient's a lot better. A lot of the mass effect, this is an early MR, is even better than this now. His walking is much better. His double vision is getting better. Facial nerves intact. And he's very well. And we're going to come back for a second stage. Okay. And that was the case. Thank you very much.